Hey guys, Woodruff here. We're gonna go over the rest of lower respiratory, and effectively this video, the purpose of it, it's a long lecture or a more extended lecture, where effectively this is what I would be doing in class. Of course, there's more activities and other stuff too that my poor people that are in my class have to go through to bring the information together, but this is a video more for in-depth or looking deeper into these topics. If you're looking for something more surface level or something more of a summary, check out some of the other videos under Unit 1 for more information. So our last video left us off with two more disorders. Well, actually officially three, but one's kind of minor, but two major disorders and one minor disorder. So we're going to finish up talking about lower respiratory and talking about asthma, COPD, and then the last one is environmental lung disease. So let's talk about asthma. Asthma and COPD are two heavy hitters. You're going to see them a lot in practice, and you're also going to see them a lot on exams. They're major problems. They're very prevalent. So having a good knowledge about these is super important. So let's talk about asthma. So before, when we talked about hypersensitivity disorders, I mentioned that asthma is officially classified as a hypersensitivity disorder. So then we have to go back in our brain and be like, okay, well, what was hypersensitivity? Oh yeah, it was an overreaction. Like think someone who is hypersensitive to things. Well, your body is just over responding to allergens. And we'll talk about what some of those allergens are here in a minute, but over responding to allergens. And what happens in this case is that there's bronchoconstriction, or your airways start to constrict and you start to produce mucus to try to get rid of the particles, inflammation and stuff like that. And so, at the end of the day, the airway becomes very narrow because it's already narrow because it's constricting. And then also there is the mucus building up, which leads to what do you call it, an even more narrow airway, which leads to like an oxygenation problem. They cannot get oxygen in. It's also hard to get CO2 out. It's like they have a lot of trouble as a whole with gas exchange. Overall, you can kind of think of this like a blockage or an obstruction. Like there is a inability in order to, because there's just such a narrow airway and it's so full of mucus, what can get by, it's just, there's a lot of turbulence, if you want to think of it, to get stuff in and out. This is something that can get better. And I get students all the time that are like, oh yeah, I outgrew my asthma, or used to have asthma, I don't have it anymore. And that's definitely, I did some Googling and stuff like that, that it is something that is a thing. But just keep in mind that once you have asthma, you always have asthma, so it can come back. Or, a lot of times people think they outgrow it, but, then sometimes those allergies hit you hard. So it kind of just depends. Some people, they're older and still suffering from it. Some people, it more affects them when they're young. And then as they get older, it gets better. So, but this is considered a chronic condition officially. So, someone who has a history of asthma, you always want to be keeping an eye out for symptoms. So what does a patient with asthma complain about? So a patient with asthma is going to complain usually of anxiety. So if you can't breathe, it is very anxiety producing when you cannot breathe and you feel like, oh my God, I cannot get a breath in or out. As someone who has asthma herself, it is definitely something like where, like when you feel like you can't breathe, you get kind of in that panic mode. And then other symptoms that the patient may have is like a feeling like their chest is being squeezed, or like chest tightness. They can also complain of wheezing, which I'll talk about in a second, or dyspnea, shortness of breath, difficulty breathing. And so the wheezing, so if you remember back when I talked about pneumonia and tuberculosis, those are lung infections and they're going to have wet lung sounds because, and also this includes pleural effusion too. They're all going to have like kind of coarse crackles or wet lung sounds. Whereas when we're talking about restrictive airway, now we're going to move into what are called wheezes. And what wheezes are effectively, it's a whistling kind of sound, and it's the sound of pretty much air trying to move past all of the mucus. So when there's, so anytime you hear the word wheeze, or you hear wheezing, or you see the word wheezing on an exam, you should think narrow airway. So you should think wet lung sounds. That's going to, like the coarse crackles, rhonchi, that's going to be associated with infection or fluid. Whereas wheezing, narrow airway, you should think asthma, COPD. All right. So I said there's a variety of triggers. So it's going to be very similar to allergic rhinitis, where they can have like animal fur can get to them. Mites and molds can be irritating to them. Pollen is a common one, especially in Texas. Cigarette smoke, perfumes. That's why definitely take it seriously. If you work somewhere, I worked. Well, actually, it was at where I work now. There was a secretary that was super allergic to scents, and I used to always be like, well, it's much more important for me to not have to smell this poop on my my patient just had, after I cleaned him up and everything, then I'm sure it's not that bad. But I mean, she had a serious reaction. She had to walk away. There's one that she had to leave because someone sprayed some like Febreze or something to make it smell better, and she just could not stand it. She couldn't breathe. So just know, like for you, it might just be like, oh, that's like, that's a little overpowering. But for them, it's literally like, I can't breathe when you do this. So, and that's why as nurses, generally we're not supposed to be wearing like strong scents and stuff like that, even like lotions that have strong scents, because a lot of people can be sensitive to them. Other triggers might be infection, chemicals, so people that work around a lot of chemicals, and then certain medications as well can be triggers, things like beta blockers and stuff like that. Other considerations is that if you, we haven't talked about GERD yet this semester, that will be in our last section in Unit 4, but GERD or gastroesophageal reflux disease can make asthma worse. And you have to understand how this probably would make sense, because you have acid that can back up, you can get regurgitation back into your lungs, which can cause more irritation to your airways. And then the symptoms are going to be worse with stress. So when I have students that have asthma, I always say like during the semester, their symptoms are out of control. So yes, nursing school is a trigger for asthma for sure. So I want to bring up a important concept about asthma when it comes to asthma and breath sounds. And especially, we talked about wheezing being the sound of whistling, and it's the sound of air moving by all that mucus that's in your airway. In most, my damn cat. So yes, one second, sorry, trying to get rid of her. And my damn cat is not a part of this presentation, by the way. I'm not trying to say something about that. So hold on one second. I'm going to try to lock her up for a second so that I can give my full attention. I'm back. So, and the reason I don't just start over, just so you know, is that I am not trying to become famous. I am not trying to make some fancy videos. And I've had a student complain in the past about like, man, I could hear your stomach rumbling. I could hear your cat. And, I'm a human just like you. And we gotta, I don't think that it's going to hopefully take away from the quality of my video, because maybe it'll actually help to show you that even your professors, they have lives and things too going on. And anytime that, I want to get something accomplished, there's always something or someone there to interrupt me. But needless to say, getting back to this important concept. So we were talking about wheezing. We were talking about the, it's the air moving against that resistance because there's all the mucus in the airway. And so effectively, when we're talking about severity, like, you can, and I think I was going to bring up the fact that usually it's going to be expiratory wheezing. This is something that especially, it will make a lot more sense when we're talking about COPD too, is that a lot of people think that the hard thing to do is to take a breath in, but taking a breath in is actually a passive process. Like literally, the atmosphere forces air into your lungs, regardless of whether you want to take a breath in. The atmosphere forces your air into your lungs. But exhalation is a more, like exhalation seems like so easy, but it's actually, you have to do the work there. Or in other words, there's more work to exhale than there is to inhale. So most of the patients, with asthma COPD, they have more trouble exhaling because it takes more effort, and they have all this resistance, all this mucus that's building up in their airway, which makes it that much harder to get it out. So they have more resistance to exhale than they do to inhale. And so as a whole, when we're looking at this, the reason that I'm bringing that up is that more commonly you're going to hear what are called expiratory wheezes, or wheezes on that whistling sound when people are exhaling versus inhaling, but they can possibly have both. But needless to say, getting back to it. like having wheezing, it sounds like it's a really bad thing. You're like, oh my God, they're wheezing really bad. Their airway might be about to close. Well, maybe. Wheezing, we definitely need to get them a breathing treatment, get that airway back open. But keep in mind that wheezing is actually, like, if nothing else, a sign that at least there's still air moving. What we're really going to worry about in a patient with asthma is when they have diminished or absent sounds, because if they're diminished or absent, then that's usually going to be a sign of like, whoa, there's no air moving, like, and that's going to be what's more scary than that wheezing sound. So in other words, what I'm trying to say here is that if you were in a situation where you had a patient with asthma and they were having, really loud wheezing, and you're like, oh my God, that's really bad. That's not as scary as them having no wheezing, or like I should say, like no sounds. So at least that sound shows that there's some sort of airway movement. So overall, what I'm trying to say is that diminished or absent sounds are not okay in a patient with asthma. When we talk about COPD, we'll talk about how they can have diminished sounds because they have an alveoli issue. But patients with asthma should not have diminished or absent sounds because it can be a sign that they are literally not moving any air. Let's see if I can get this. All right. So there's a variety of medications that we can use. I know that you're tired of medications, but yes, there's more. And so there's going to be different medications, and I'll talk about this more when we talk about diabetes too. But effectively, we have medications that are going to help right now, and then there's going to be medications that are going to help later, like more long-term over time. Because the goal here is, of course, that I don't want to be having asthma attacks all the time. My goal in asthma is not to be rescued constantly from attacks. My goal is to not have attacks. First and foremost, we're going to talk about your rescue medications, the ones that are going to rescue you. But just keep in mind, yes, I need to be rescued if I'm, my airway's closing, but the goal is not to always have to be rescued. So the medications that open the airway fast during an emergency or during an attack are going to be what are called SABAs, or short-acting beta agonists. This is the one that most people are familiar with, known as albuterol. And I have just some mnemonics and stuff there. So like I mentioned, there can be too much of a good thing. You can build up a tolerance with this rescue inhaler. So if you have a patient that comes in and says, hey, I've had to use my inhaler a lot more lately, that's not like, oh, great job. Like, that's telling you that something's not working. So it's going to be the same thing. Like I said, we're going to relate this when we talk about insulin. There's like rapid insulins, and then there's more long-acting insulins. Okay, well, it's great that you're taking your medication, but we don't want you to have to be using more of your medication. We want, we're going to try to keep it where you're more stable over time. And so anyway, it'll make more sense when I'm talking about the long-acting stuff here in a minute. Common side effects of albuterol are going to be things like, and I'm saying albuterol, but any SABA are going to be things like anxiety that can kind of, it effectively stimulates some fight or flight stuff, because it's opening your airway. And so you have this anxiety, it increases your heart rate. So if someone already has like a baseline high heart rate, like I know at my hospital, the protocol is generally like if their heart rate's above 120, we're going to hold that medication, and respiratory will hold it. Kind of depends on the patient, but yes, if their heart rates are kind of running high, we have to keep that in mind that this is only going to increase it more. And then with that as well, hypertension, that's some of that sympathetic nervous system activation. There's albuterol and there's levoalbuterol, and the Xopenex, this other one, this one has less of the anxiety, and like you can get like tremors and stuff like that, just like the anxiety, nervousness. The levoalbuterol has a little bit less of those symptoms, but still can have them too. But anyway, so this is my rescue. This is the one that this is going to be. So when you think rescue, this is usually going to be the one that you want to do first. And what it's going to do, it's going to open my airway. And so it's going, there's, I have all this constricted airway with asthma, and what it's going to do is going to open that airway so I can breathe easier. So then over time, there also are long-acting forms. So again, I want to utilize my long-acting medications, especially some people with asthma, they just have attacks very rarely, occasionally, and so they may not need a long-acting. But if I'm regularly, especially like I said, in Texas, there's so many allergens. If I'm regularly needing to use my short-acting, then usually they're going to start adding in some long-acting stuff or some other medications so that I'm not having to use the rescue all the time. Because like I said, you can build up a tolerance, and it can, it's not, the goal is not to constantly be rescued. So these can work up to 12 hours. They're not for acute exacerbation. So if I give this and someone's having an acute attack, it is not going to be helpful. I need that fast acting, that SABA. And here's some examples of them. They end in EROL instead of just the OLs. So yeah. So what other medications can we use? Yes, there's more. There's also inhaled corticosteroids. So these help in two ways. First, they help because they stop, they decrease inflammation. So if I already have kind of like a constricted or swollen airway, they're going to decrease some of that inflammation. But steroids also suppress your immune system. And since this, the problem in asthma is an overreaction of my immune system, where my immune system is overreacting to things entering my body, this can help also, so my body doesn't react so much. This is also good for more long-term, that if I'm taking like an inhaled steroid long-term, it can stop me from having so many attacks. Something to keep in mind is these inhaled steroids are great, and we do use them. You know, when patients come in, like we start them, if they're not already on them, they're going to get started on this, but just realize that these are not like working like right now, like albuterol literally within seconds can open your airway. Whereas, you know, a patient that's getting steroids, it's going to start working, but it's not going to work as like immediately like, ta-da, like here, your airway is now open. So it takes time. So we do consider that this is not one for an acute attack, even though you might see a patient get it, because it takes some time to build up. So we're going to start to give it so it can start working. But you're going to see in general, the theme with steroids is it takes a little bit of time. So steroids are never going to be your first choice. Like if you had to choose between albuterol and steroids for rescuing, it's always going to be albuterol first. Other things to consider, because this does suppress your immune system, is that it's local, is that especially if it's not administered correctly, they can get thrush or a yeast infection in their mouth. So you want to teach the patient to rinse their mouth out after, and then use a spacer, which can sometimes help from medication getting kind of stuck on that tongue and them having a higher chance of thrush. So yes, and these aren't as much systemically absorbed, so we're not worried as much about the blood glucose and stuff like that. We're just more worried about the local possibility of infection. And then again, this is not going to be like, hey, I'm having an acute asthma attack, I have to take my steroid first. We'll probably take a steroid, but that's not going to be my first choice. So talking about these medications, there's what are called metered dose inhalers, or MDIs, and then there are DPIs, which are dry powder inhalers. And a lot of your like long acting and steroids and stuff are a lot of times given through the DPI, where your metered dose inhaler is going to be like your albuterol or your fast acting stuff. But it just depends on the thing. You don't have to know that in depth, that one is one versus the other, but you do need to know the teaching you need to do for one versus the other. So the difference here is a metered dose inhaler, we want to shake this one before use, where a dry powder, we do not shake it. And then when we're breathing in the medication for the metered dose inhaler, we're going to breathe in slowly, and we wait at least 1 minute between puffs. And we just want to make sure to do really good oral care with these. Spacers are super helpful, which I'll talk about in a second. The dry powder inhaler, the big difference, aside from no shaking, is that we breathe it in quickly. So effectively, if you think about it, if I had an inhaler here, with a metered dose inhaler, I exhale. And then like I would have my spacer and stuff in, I push down on my inhaler, and then I try to take a slow, deep breath in, I hold it, and then and then I wait at least 1 minute between puffs. Whereas with the dry powder inhaler, there's no shaking it. And then I want to do a real quick inhale, and that's just based on, because of how it's dispensed, why it works that way. So MDI, I want to do slow and shake it before. DPI, no shaking, quick breath. And the spacer I was talking about, this is the thing I was talking about before that can help to decrease your risk of thrush. It allows you to inhale slowly. And a lot of people, they just can't coordinate, especially as people get older, they struggle to coordinate like pushing and then taking a slow, deep breath. So it effectively is like a tube that goes in your mouth, and then the medicine stays in that tube, so you can slowly inhale, so you don't have to worry about coordinating so much. And it reduces the medication that's lost in your mouth and also in the air. Super helpful. So also a side note about asthma and oxygen. So keep in mind that, asthma is generally an oxygenation issue. I know I told you they have trouble exhaling, so you'd think it'd be a carbon dioxide issue, but it's not. It is it's a problem with getting oxygen in, because and I don't want to get confusing here now. So I mean, I was bringing up before that it's harder to exhale than it is to inhale, and so they do have to exert more effort, and they're going to sometimes have that prolonged expiration and a lot of the same stuff like COPD. But keep in mind that the reason I'm bringing up asthma and oxygen as an issue here is because when I talk about COPD and oxygen, Oxygen cannot save a patient with COPD. Like that's not their issue. It's not that they're like, oh my God, they're really low on oxygen. But with asthma, it is the issue. Like they cannot, they're struggling with both. Like they cannot get oxygen in. They can have air trapping too, where things that they're just not getting oxygen in the way that they need to. But something I want to note is that like when you're on a test question, you're looking and you're like, okay, patient has asthma. Do I apply oxygen first, or do I give a short acting beta agonist first? With this patient, remember what the problem is. Yes, there's like a lack of oxygen, but that oxygen cannot get in as long as my airway is closed or constricted. So my first priority is always going to be to open the airway first with a short acting beta agonist, and then I can apply that oxygen. So they may need supplemental or supportive oxygen. Their oxygenation may improve once their airway is actually open and no longer constricted. So in other words, oxygen is good. It's a good intervention to choose for a patient with asthma, but it is not as good as something that is going to open the airway. So if inhalers are not effective, and we still teach this, even though, I mean, in the years that I've worked in a hospital, I have only seen this given maybe once. This is an IV or PO medication, and also like the most common one is known as Theophylline. This is kind of like the last ditch effort. If we try everything else and nothing else is working, this is the medication we'll try. And the reason that it's the last ditch effort is it's super toxic. It's very unpredictable. There's lots of drug interactions. They start having some very serious things if it's getting toxic. We do not use it for acute attacks, but it can help with maintenance, or if like we're trying everything and just nothing is working, we can give this. But yes, it's not very commonly used, but occasionally you still see it on NCLEX, which is why we still teach it. So like I said, the goal in asthma is not to just keep constantly saving them when their airway is closing. It's to stop their airway from closing all the time, stop their body from overreacting all the time. So we can use some of those same medications we talked about for like allergic rhinitis, the preventative, like the leukotriene modifiers, the LTRAs, things like that. We talked about the other ones like the mast cell stabilizers. Those can be used as well. But knowing their triggers and avoiding them is key. So that the whole point is not just to oh, hey, well, I'm going to go do X, Y, and Z activity daily. But I have my inhaler, so I'll be okay. The whole goal is that we don't want them to have as many attacks, because asthma is serious business. I'll talk about that soon. Patient will also have what's called a peak flow meter at home and an asthma action plan. So a peak flow meter, what this is effectively is it's a device that they exhale into that tells how much resistance is in their airway. So effectively, it's kind of telling them, hey, is your airway starting to get constricted? So what they do with this is that they have to, they blow into this device. Well, first we get a baseline. So like when they're not having any attacks, things are going well for a few weeks, we get a measure of what's their personal best, like what's the best number we can get, or like the least amount of resistance that we can get on this patient. Then on the next page, I'll talk about we create an action plan. And so that way they can kind of know like, hey, here's when you need to take this medicine. Here's when you need to call your doctor. Here's when you need to call 911, that kind of stuff. But the peak flow meter, it's not something, we don't use this in the hospital. Like I'm not like, oh, here, let me check my patient's peak flow. This is something they use at home. We can do spirometry testing and stuff like that in the hospital, which I've never seen because it's more of an outpatient thing. But we can do spirometry, which is a very similar thing, but just know a peak flow meter is like a device to have at home. Think of it like a glucometer for the patient to have at home to see how they're doing. Yeah, the peak flow meter is going to help to see how well they're exhaling. And like, again, it's measuring that resistance. How much resistance is it to force that air out? And if my airway is constricted or if it's full of mucus, it's not going to be pretty. So asthma action plan, effectively, there's a green zone, yellow zone, and red zone. And all of these zones are measuring kind of how the patient's doing. So there's a green zone, which is where you're at least 80% of whatever that personal best is that we measured. And that usually tells you, hey, things are pretty stable now. It doesn't mean you don't need to take any medications. I know I was saying, hey, I'll tell you when to take medications, but more so what I mean is that in the green zone, you should always be taking your maintenance medications regularly. There's never a time with asthma asthma where you're like, hey, you know what, things are like, and I know that I said that you can't outgrow, but what I mean is that there's someone who's actively experiencing asthma, like there's never like a time where you're just like, oh, I only have to take medicines when I'm having a bad attack. Like there's maintenance medications that are helping, again, if you remember, to keep things stable so I don't have to be rescued all the time. So the green zone are going to, the green zone is going to be pretty much where things are good for now, but keep taking my regular maintenance medications and use my SABA as needed. And I didn't talk about this, but we can also use that short-acting beta agonist or that SABA prior to exposure to what do you call it, like allergens and stuff like that. So example, for me, a lot of times one of my triggers was exercise. And so what I would do is before I would go for a run, I would take my inhaler and I would take 2 puffs of my inhaler to help open my airway to prepare me for the activity. So that's the green zone. And then there's the yellow zone. This is where you're at 50 to 80% of your personal best. This is kind of like a caution, like a warning, like slow down. You always, during this time that you usually want to take your SABA, and if there's no improvement in your peak flow, you're going to need to call your doctor or maybe go to the hospital. Then red zone is less than 50% of personal best. Seek help now, take your SABA, call your healthcare provider. Probably most likely you're going to the emergency department. And here's an example of this. And this just kind of shows you like, hey, things are going well. And this is what they'll give the patient, how many puffs to take, what to do next, et cetera. And that way that they can kind of know like what to do. Because the key here, the reason that they need these plans, because I haven't touched on this yet, is asthma, like as much as, there's some people that live with it their whole life and don't have too many issues with it. I have seen so many young people die of anoxic brain injuries, which is where your brain is without oxygen. What happens? They're at home. They are not keeping up with their medicines, or they don't have their medicines, et cetera, and they end up they're at home and their airway closes, and there's no one there to help them, and it's just so sad because most people with asthma are usually younger. And so it's a really, really shame to see such young people, have to lose their lives over something that can be managed. And I'm not, putting that on them, because for some of them, it was just a really unfortunate series of events. But for a lot of people, this is like, it's all about maintenance. You have to keep up with this. And it's kind of like when we talk, I bring this up multiple times. It's like hypertension, where like, you don't have a lot of symptoms. And so with people with asthma, they have symptoms, but when like the big thing that I always say the difference between asthma and COPD is people with asthma, that when they have an attack, they're feeling it. It's miserable, but there's times that they're fine. They're like out in the world and not, experiencing a single symptom. So it's really hard to keep up with something that only bothers you sometimes. And then after a while, you can definitely kind of get a little complacent and be like, oh, okay, I've got this. I'm okay now. So it's just so key to keep up with general maintenance with their medications, regular health screens, and not underestimating their asthma for sure. Always keeping their medications on them, and also making sure other people know how to help them too if they're having an attack. So what other interventions can help for asthma? If they're overweight, weight loss can help. 2 to 3 liters of fluid a day. Thinning those secretions is key because it'll help, if nothing else, with some of that airway clearance if they are having an attack. Exercise is tolerated, and like I mentioned, like for me, it was because it was a trigger, but in general, it's great to take a SABA, especially before strenuous exercise. Good nutrition and rest are key, and getting help early if symptoms are not improving. When these people come into the ER, there's sometimes, if they're having a really serious exacerbation, they can, you're probably thinking like, oh, they take 2 puffs of their SABA and they're good. Well, their airway can continue to close, kind of like anaphylaxis. And so, I've gotten a patient in the ICU before where they'd received up to like 25 or 30 back-to-back albuterol treatments, and their airway was still closing. So, it's really intense. Asthma can be super serious and super deadly. So definitely education and compliance are key. So let's move into COPD. So COPD, on the other hand, when I was talking about asthma, being like reversible-ish, possibly for some people. COPD is not. It is a chronic and non-reversible. It's an inflammatory disorder, or inflammatory disease, or inflammatory response, however you want to say it. Most people know COPD because of cigarette smoking. And I always, I always say, as a nursing student, it really helps to get an image in your head of what this patient looks like. And I know for me, I've always had this image of this person who, like there's like after a while, like COPD was the easiest one for me, that after a while you see COPD patients and a lot of them look the same. They kind of have a similar sound to their voice. They have kind of a sunken in appearance a lot of times, because we'll talk about like one of the symptoms is that they have weight loss and stuff like that. But they have a certain look to them, and it really helps as a nursing student to kind of get an idea of what these patients look like, and you can start to pick them out. And so I always tell the funny story of when I went to find a new daycare for my son, that there was like this one woman, she seemed super nice, but I'm like looking at her, I'm like, she has COPD. Like there's no way in hell that she doesn't have COPD. Like just the sound of her voice, the way she looked, and I could even like smell cigarettes on her. And I remember like she went outside, and then I asked at the front desk, and I was like, does she smoke while she's here, at work? And then they're sitting there, they're like, oh yeah, but don't worry, she changes her apron, or she takes her apron off. And I was like, you do realize it's in her fingertips, on her mouth, and she's kissing these little babies, like, so like it was an easy, fast no for me, for my baby. When he was a baby, I definitely didn't want him, being held and with the cigarette stuff all over her, because she was like she went out for multiple breaks just when we were there for a short period of time. But anyway, this is not a shame education thing over cigarette smoking, but just realize that, most of the time you see these patients, like you're going to start to get a view of what they look like. And a lot of them will look very similar and have kind of an appearance to their skin. And almost all of them have smoked cigarettes. There are some genes that they're now connecting with COPD that, there's people that are non-smokers that are getting COPD, but 9 times out of 10, they are cigarette smokers. So pretty much what's going on here, it's similar to asthma in that there is a constricted airway and mucus production, but the difference here is that it's a problem, like asthma is just a problem in the airways, whereas COPD actually goes all the way down into the air sacs. What happens is that the air sacs get damaged from the inflammation, and they get less elastic or less stretchy or less able, like, because pretty much like air goes in and they kind of open, close, what happens with the inflammation stuff over time is they become less elastic, and then air just gets kind of stuck in them. They're not working how they're supposed to. And then effectively what happens is CO2 gets stuck in them and cannot be exhaled. And so the big difference here is there is massive CO2 retention for patients with COPD. And you can remember it because it's got the CO in the name. So this is kind of an example, normal lungs, they have these beautiful alveoli, lots of space for air to get in, oxygen to get in, and CO2 to get out. But, see these kind of like very like, what do you call it? I want to say mushed, but that's not the official, that's not a good, way to describe it, but mushed up alveoli. There's no gas exchange that can happen there. They have this plus a constricted airway, which leads to a lot of difficulty with breathing. So this patient usually has like a gradual onset. It's not a sudden thing. They can have acute exacerbations, but it's usually kind of a gradual onset. They usually complain of having like a long-term cough for a long time. That's usually one of the first symptoms they present with. They can have that expiratory wheezing, just like the patient with asthma. And then I said some of those other symptoms, they commonly have fatigue or are feeling very weak. They can also have a lot of weight loss of appetite, because it's very hard to breathe and eat at the same time. Cigarettes also can commonly lead to weight loss in general and decrease your appetite. And then activity intolerance. They're going to struggle to breathe and do a lot of things at the same time. So breathe and move at the same time. So other things you might notice about this patient is they can do what's called, let's put it here, pursed lip breathing, where they're kind of, it almost looks like they're trying to kiss you, but they're not, trust me. Effectively what they're trying to do, because a lot of people don't really see it this way, but this is actually like it's something you can teach them to do, but it's sometimes, you'll see people do this that are struggling to breathe, is that effectively what your body's trying to do is it's so hard to exhale. The longer that you exhale, the more effective you're going to be able to get that CO2 off. So the pursed lip breathing is a technique or maneuver that you can do or your body can do in order to help to get extra CO2 off. So the blowing out of that is going to help in order to, the longer your exhale is, the more gas exchange that's happening. So if I can prolong that exhale, I'm getting some more of that CO2 off. And that's so key, because we're going to talk about this, but the big issue here is, who cares? I'm holding on to CO2. Well, that's a waste product. And if I build up so much waste, then I can definitely have some serious issues. Like most patients, like for patients that I see with COPD, Um, you know, there's times that their CO2 has been undetected, like, you know, undetectable, like it's so high. And some people, they live with, well, not some people, most people with COPD live with a higher CO2, but it doesn't mean that they're doing well with that always. So we definitely want to try to get out as much CO2 as possible. They have a larger diameter to their chest. So normally, you know, like kind of if you're looking at yourself from the side and then across the front, those are not equal, like the length from side to side and then from front to back. But what you can get with COPD is what's called a barrel chest. What a barrel chest is effectively, it's from that air trapping. All those alveoli are full of air, but air can actually get in your bloodstream. It's just trapped. And so you kind of get this hyperinflation of the lungs, which leads to this barrel chest appearance, which is kind of like this last slide, what I was trying to say with the barrel chest. You might also notice that they're in this position. It's known as the tripod position. It's kind of like a sitting forward position. It also helps to compensate and give them a sense of that they're breathing better. And I'll talk about why here in a little bit. So what's going to help them to breathe better? So COPD patients do need help with opening their airway, like with the SABAs and stuff like that. But a lot of my care for a patient with COPD is less focused on opening their airway and more focused on an effective breathing pattern or effective exhalation, specifically getting that CO2 out. So head of bed elevated is key for maximum lung expansion and gas exchange. I think I explained this in the other video on the lecture, but effectively what you want to think about with this is that if I'm sitting with my back up against the bed or laying down, the front of my chest can expand out, but the back of my chest cannot expand back because I have something pushing against it. But if I'm sitting in that upright tripod position, or if I have the head of bed elevated and I'm sitting forward, that's going to really help to allow for my lungs to expand forward and back to allow for maximum expansion. The more expansion that's happening, the more gas exchange that can happen. It's giving more time for that exchange to happen. A lot of the medications are going to be the same. I'm going to do short-acting and long-acting beta agonists, inhaled corticosteroids. One that's a little bit more commonly used, it can be used for asthma too, but more commonly used in COPD is inhaled anticholinergics. I'll talk about those on the next slide. And then Theophylline too, if nothing else works. We're going to teach them breathing exercises and retraining, like pursed lip breathing, like I mentioned, you know, trying to get them to prolong that exhale. I'm going to talk about airway clearance techniques like CPT, and then physical therapy and pulmonary rehab. And what that is learning how to move and breathe at the same time. So anticholinergics, inhaled anticholinergics specifically. This is one of the things that we use in COPD because it helps in two ways. It helps first because it helps to dry up some of those secretions that are excessive in COPD, but it also relaxes smooth muscles in your airways, which allows for more opening long-term. Now, this is not for acute attacks, exacerbations. Usually there is a short-acting form that can be used if they're like the SABAs and stuff aren't working, but generally this is not your first line unless the SABAs are not working or they're having a bad reaction to them. I kind of talk about that there, but these are the tropiums, or you can say that they all end in PIUM is a way to remember them. The one thing is because these are anticholinergic, the anticholinergic can help, like I said, relax smooth muscles, dry up some secretions, but it also has a lot of side effects. Like there's a lot of some serious ones, like it can cause sedation. The big scary ones that we usually talk about is urinary retention. It can definitely have changes to your heart rate. It can increase your heart rate. It can also cause problems with your vision, etc. People can complain of dry mouth. You can give them lozenges and stuff like that if that's an issue for them. But do really want to look for these, especially the urinary retention, because we do not want a bladder that explodes. So let's talk about airway clearance techniques. So this is all about, when I say airway clearance, it's about clearing the airway, opening the airway, getting sputum and mucus up. So one thing is called a huff cough. And in my class, I kind of show videos on all these. So I'm going to try to describe them the best that I can. But a huff cough is like kind of a forced cough, like, and so it's like where you're forcing air out, and that helps to get up some mucus. There's also percussion, which is going to be like this. It's either where you use a device that kind of helps to shake stuff up, or literally, kind of like in this first picture here, where this person's literally hitting on the person. You may think, oh, there's no way that we actually do this, but this happens all the time. Sometimes the hands are more effective than some of these devices. So I've seen people just sit there and hit on someone's back and try to get up. It helps to break up the mucus if it's stuck in the airway. And then vibration, same kind of concept where we're trying to break stuff up. There's also what's called, I'm going to talk about CPT, I didn't forget. I'm just going to save it for last. There's also what's called PEP therapy, which is a special device that effectively creates like a vibration in the airway and helps to break up mucus and helps you to exhale, it helps to improve your airway clearance as well and break up some mucus that may be stuck in there and provides some opening of the airway as well, which is not open, I don't want to say opening the airway, but it helps to keep your alveoli open. So additionally, the like most common thing that we use when people are having trouble with their sputum is what's called CPT. It helps get more mucus up and out, and that's chest percussion therapy is what that stands for. And so this has two parts. It has the part where we're doing kind of percussion and vibration, where we're trying to like kind of beating on them to get the stuff up. And then there's also like, well, let me put it this way. Usually what happens with these patients when we do CPT is I'm going to give them a bronchodilator before, then I'm going to, and this is the respiratory therapist doing this usually, I'm going to do the percussion vibration to try to get stuff up. And a lot of times they're going to be positioned with their head down, feet up in order, and I'll show on the next page kind of some of those positions that help to get secretions up depending on where their secretions may be stuck. And effectively that's going to help me to get stuff up. So effectively postural drainage and CPT, the point of it is to open the airway, kind of beat up some of that mucus that's stuck and get it up. This should be, you have to consider their meal times. If I'm going to put them head of bed facing down, like the reverse Trendelenburg, was going to say have their head like that. If they're on tube feedings or if they've recently eaten, this is not going to be good for them. If I'm banging on their chest, this can really upset their stomach. So it should be done at least 1 hour before any meals or 3 hours after meals. We do not want them aspirating for sure. And then, like I said, we're going to give that bronchodilator first in order to help to open the airway to actually make it. Because it's great if I can sit there, beat on their chest, do all these things, but if the airway is so constricted that that mucus can't get up, it's not helpful. So I had something similar when I talked about pneumonia, but this just kind of shows different positions we can put them in. And like I said, normally they're going to be on their back and laying head of their head's going to be kind of slanted down and their feet are going to be up. That's going to help gravity to get stuff up. So I talked about with asthma how oxygen is can be helpful. That oxygen does play a role or can help a patient with asthma. With COPD, it's hard to explain this without getting you too confused, but I'm gonna do my best. Most patients with COPD need oxygen. They're gonna usually be on low level oxygen, like a couple liters, and there's not like a maximum. I know that, at least at my school that, or in previous classes, you may have learned, hey, we never go above 2 for COPD. We do, we're really looking at their O2 sats. Like for most patients with COPD, we wanna keep them 88 to 92. And that's okay for them. But so in other words, they're going to be on oxygen most likely, but oxygen's not what's fixing them or saving them. COPD is not an oxygen problem. It's a carbon dioxide or exhaling problem. And the main problem is in those air sacs and in the constricted airways. So exhalation is going to be so much more helpful. So when you're looking like, and it's saying like, hey, you have a patient with COPD, like, what do you need to do first? Like a lot of the stuff's going to be about exhaling, breathing pattern, positioning, stuff like that to help them to get that CO2 out versus like, oh my God, apply oxygen. Now, again, this is not to say that they're not going to need oxygen. A lot of them need the little bit of oxygen support. They're at home on oxygen, but oxygen is not the fix or the savior for COPD. It's not usually the first thing you should think like, oh, COPD, got to get some oxygen on them, priority. And again, they might need it, but usually the priority things are going to be head of bed elevated, teaching pursed lip breathing, tripod positioning, encouraging that prolonged exhalation, because that's really what's going to be what helps them the most at the end of the day. So I talked about how nutrition can be an issue for these patients as well. And so I said that it's hard to breathe and eat at the same time. And then they also already have like a baseline of having trouble with fatigue. So some general guidelines you can teach your patient is to rest at least 30 minutes before they eat, taking a bronchodilator, and that just helps so that they can actually have the energy to eat. Taking bronchodilators before meals can help. It opens the airway so that they are kind of like, it's the same thing I've mentioned about taking an inhaler before exercise. Same thing. Eating for a meal for patients with COPD is a lot like exercise. So avoiding exercise for at least 1 hour before and after eating. And that's just because if you're already exhausted from doing the exercise, you're not going to have the energy and everything that you need to eat. Using supplemental oxygen whenever necessary. So a lot of people will use oxygen while they eat because it helps to give them what they need in order to have the energy and ability to get through the meal. And then not 1 hour before and after, but in between meals, walking and getting out of bed and moving around helps because exercise does help stimulate appetite and increases mood, which can help with their nutritional issues. But as a whole, I want them to rest before, right before and right after, take your bronchodilator before, use oxygen during if needed, and then in between meals, at least an hour after the meal, then get up, walk around a little bit to stimulate your appetite. So what should they eat? They should be eating high calorie. And this is like the only one where you're allowed to do like high calorie and stuff like that. So like, I mean, it's not the way you want to go, but if you really want to eat a high calorie diet, smoke a bunch of cigarettes, get COPD, and it is for free. So high calorie, high protein, moderate carbs, moderate or high fat. So like, that's like a dream diet for some people. But the sad thing is when you have COPD, you really do not feel like eating. We always want them to eat their high calorie foods first. We want to get the most bang for their buck. So like nutrition goals for a patient with COPD is not about quantity, it's about quality. I want them to get the high quality foods first. They should limit their liquids at meal times because if they drink all of their fluids at meal times, then they're not going to have room for anything else that they're going to eat. If they drink like a bunch of water, they're going to get all that water in, which they do need more fluids, but they're not going to get the nutrition they need because they're going to get full up on those fluids. So fluids are good, but they should do them in between meals, not with meals. Frequent meal snacks are great, and nutritional supplements are commonly needed for these patients. So what can I teach a patient to prevent complications? So I want to make sure that they know how to give their medications correctly and they're taking them correctly. Energy conservation techniques. These are effectively where we're teaching them how to balance rest and activity. So in other words, this is not a patient that I'm going to say, hey, get all your stuff done first thing in the morning, or cluster all your stuff together. This is a patient I'm kind of like with meals where I'm going to say, hey, small things throughout the day. So spread your activities throughout the day, take breaks in between, conserve your energy. Stop smoking is a huge thing. A lot of people with COPD are like, well, I'm already kind of screwed, I might as well keep smoking. But them stopping smoking can improve their life exponentially. So it's not necessarily going to reverse their COPD, but it can definitely improve a lot of the issues that they're having. We also want them to stay immunized. This is immunized. This is a patient that's going to be high risk for infection because of that damage to the alveoli. These patients commonly come in and end up with some very serious infections. So immunization, hand hygiene, avoiding crowds and sick people are key for them. I talked about increasing fluid intake to thin out the secretions, just like the patient with asthma as well. We know we want to thin things out. Emotional status, since this is a chronic condition, they're fatigued, they're not able to do the things they used to do. And then we need to teach them about oxygen therapy, excuse me. So oxygen therapy is helpful for a patient with COPD. Like I said, they may be at home on it, that it can help improve their sleep, their mental status, and that can help them to tolerate things that they're trying to do a little bit more easily. Some people wear it around the clock and some people only use it during exercise, sleep, meals, stuff like that. Teach the patient at home to replace the cannula every 2 to 4 weeks, or if they have an infection, they definitely don't want to use a dirty cannula. And then also teach them about no smoking or flammable liquids near the oxygen or oxygen tank. And you'd be surprised that you would think it would be common sense, but it's really not. So you need to tell people they cannot smoke with the oxygen still in their nose. It will ignite. So let's talk about oxygen therapy in general. So there's a couple different ways to give oxygen. Most commonly, you're going to see in the hospital what's known as the nasal cannula, or that goes in the nose. Let me get up here like this. That has little prongs that go in the nose. The minimum I can give is 1 liter, which is 24%. And if they give you like a like a comparison, in the atmosphere without oxygen, we're all breathing 21% oxygen. So it's just a little bump up. And then they can get up to 6 liters on regular nasal cannula. which is 44%. This nasal cannula is a great choice. The patient can still eat, talk, cough, do what they need to do, but it can dry out your nose. So a lot of times we add humidity to the oxygen equipment in order to prevent the dryness in the nose. And because normally the nose is your humidifier, but these prongs actually bypass, and so you don't get that same humidity. Sorry, I always get respiratory problems when I'm trying to do my lectures. There's also breakdown of the skin. So we want to protect the ears. There's kind of these like little ear covers here that they can use that they actually come as a part of the device itself. Or sometimes people just put like 4x4s or 2x2s around their ears, etc., like gauze. And there's also what's known as high flow nasal cannula, and that's what is over here. It can deliver up to 100% oxygen and also provides flow, or kind of like a push to force the air in. It adds something called PEEP, which helps to keep the alveoli inflated, which is super helpful for a lot of patients. It's more comfortable, has more flexible tubing, but it has the same skin considerations. It's automatically humidified. So if we need to step it up, we can use that. So as the nurse, it's really important that you note like that it's your job to know how much oxygen your patient's on. So don't just look and say, oh, hey, they're on a nasal cannula. Well, great. How much oxygen are they on? So if they're on a nasal cannula, they're going to be, on any oxygen device, they're going to usually be attached to a cylinder like this. And so I'm always going to look and see how much they're on. Like, for example, this patient here is on 4 liters. So I'm kind of looking at where the ball is to get an idea of how many liters they're on. This is an example of a high flow O2. And so I have to know how much flow they're on and what percentage of oxygen they're on as well. So just know it's your job as the nurse to look at not only just the device and what's on the patient, their face, etc. You need to follow that all the way to see how much they're on. Because I mean, I can't tell you how many times a report I got on, oh yeah, they're on this much oxygen. I go in and there was on something very different. So there's also masks. These provide more higher concentrations if I need more higher concentrations. So some general considerations for masks are that there's sometimes more pieces, or they require assembly, especially with like a venti or venturi mask. They're harder to keep clean. And so we definitely have to consider about concern for infection, want to regularly keep them clean or change them out, especially with the mouth. I've had people kind of vomit in them and it's like, oh, got to definitely keep it clean. It creates more of eating and communication barriers. So we have to kind of balance like letting them eat if they're allowed to, and also making sure they're breathing well enough. And they can also, again, get skin breakdown around the mask. There's more pressure points to consider. So there's a simple face mask, which can give between 35 to 50% oxygen. There's what's called a venti mask. And this is something that's actually pretty cool for COPD, is that, we want the least amount of oxygen possible for a COPD patient. I'm not going to go into, because I didn't talk about it, but there's like there's a theory about that them being a little bit low on oxygen helps to drive for them to breathe and allows them to breathe better. When I first started teaching, I looked into it, and there's a lot of people that actually said that that's not true. And I don't know, there's mixed research on it. But at the end of the day, just remember that the goal in COPD is not to like hyperoxygenate them 100%. We want them to be on that 88 to 92. And what can help is having something like a venti mask, because it allows me to give precise concentration. So if I want the least amount of oxygen that I need in order to support this patient, this is a good option. Now, am I saying that every patient with COPD should have a venti mask? Absolutely not. We want the least invasive and like the least amount of oxygen. So if they can be on nasal cannula, that's what they're going to be on. But if they need to be on more, instead of putting them on a mask where it's automatically going to give them 50 or 100%, I can put them on a venti mask where I can control the percentage of oxygen they're receiving. So this can be helpful for those patients. I can give anywhere between 24 and 50% O2. There's also what's called a non-rebreather. And I have pictures of these on the next slide. This is another mask that's going to allow me to give like up to 100% oxygen. It's usually the thing that patients come to us on after surgery or right before they need to get a breathing tube if they're really not doing well. Something to consider with these is, in order for it to work properly, the bag has to be inflated. So just kind of like I have to check the oxygen cylinder to see like, or the oximeter on the wall to see how many liters of oxygen they're on. It's also my job as the nurse to make sure that, like with the venti mask. Like you can see here, like there's different colors and stuff like that. And I attach this to the tubing. I need to make sure it's set up correctly. Otherwise, they're not getting what they need to get. So with the non-rebreather, the bag that's attached has to stay inflated or it's not going to work correctly. So here's a simple face mask here. And then on the right over here, this is a non-rebreather, and you can see the bag there, and it is inflated, which means it is doing what it's supposed to do. So last but not least, let's talk about environmental lung disease. So I have this at the end just because it's very similar and looks a lot like COPD, but it has a different cause. It's a chronic inflammation of the lung, and it's usually related to chemical exposure or dust. So these are people that may have been exposed to asbestos, or could be, people that are coal workers that work in a coal mine, and then farmers, because of pesticides, are also at risk for this. The thing with this is many people have no symptoms of environmental lung disease till 10, 15 years later. They go to their occupational health and have a lot of signs like COPD, like they can't breathe, they're having dyspnea, they're having wheezing, weight loss, stuff like that. These patients, mostly we treat them a lot like COPD patients, oxygen therapy, bronchodilators. We do less CPT. We're trying to get thin out their secretions, hydrate them, etc. But a lot of management of environmental lung disease is prevention. And so we want to make sure that people are wearing protective equipment, masks, and other things if they're in an area where they're going to be exposed to chemicals, avoiding chemicals when all possible, and then having regular checkups to really see how things are going. Because once this is here, there is no, it's non-reversible. And I've had a few patients that have some pretty sad stories about getting exposed to things in their workplace and not even knowing it, then years later just having really, really severe lung disease. So definitely good to know who's high risk for this. Anyway, that is the end of the respiratory lecture. I hope that this was as illuminating for you as it was for me. I will see you next time. Bye.